When someone is diagnosed with cancer, one of the first questions is simple. What exactly is it? The answer to that question usually comes from a place that most patients never see, the pathology lab, where tumor tissue from a biopsy is examined to determine what type of cancer it is, how aggressive it may be, and sometimes even which treatments are most likely to work. For people with neuroendocrine cancer, that information can be especially important because these cancers can look similar under the microscope, but behave very differently. In this episode of NETWise, we'll explore what pathology is through the voices of clinicians, pathologists, researchers, and patients, and why it plays such a critical role in diagnosis, and how understanding pathology and demystifying it can help guide the decisions that come next. I'm Jessica Thomas, Director of Patient Education at NetRF, and you're listening to NETWise, the podcast designed to inform, empower, and guide patients and caregivers through the world of neuroendocrine cancer. In many ways, pathology is where the story of a diagnosis truly begins. Before treatment plans, before second opinions. It begins with a biopsy, a small piece of tissue that holds an extraordinary amount of information. Information that can help answer not only whether something is cancer, but what kind of cancer it is, how fast it may be growing, and what treatments may make the most sense. Dr. Aman Chauhan breaks this down for us in simple terms to help us understand.
Anytime somebody is diagnosed with a mass or an abnormal growth, that doesn't automatically mean it's a cancer. The only gold standard way to know if we are dealing with a cancer or an infection or a benign condition is by biopsy. There is no blood test, there is no scans. Oftentimes patients ask us, can we do something else? No. It's the gold standard to confirm a diagnosis is biopsy. It's a procedure where we get a little piece of the tissue. We could put a needle biopsy, could be a surgical biopsy where we cut it out. So different forms. But what it means is we're getting a little piece of tissue, take that tissue, process it, and look it under the microscope through our naked eyes. The doctors who are trained to do this are called pathologists.
For most patients, pathology enters the story quietly. It happens after a scan finds something unexpected, or after a doctor recommends a biopsy. That small piece of tissue is taken from the body and sent to a lab. And then the waiting begins. For patients, that wait can feel endless, a stretch of time where life is still moving on around you. But internally, everything has started to shift. Paige Corrent, a patient diagnosed with a high-grade small cell neuroendocrine carcinoma, remembers that period all too well.
They said it would be like 5 days. So on the 5th day, I started calling. Where are my results? I called the doctor that ordered it, and where the biopsy was taken, I called there too. And there was a bit of a delay. So I think I called on a Tuesday morning. I didn't hear on Tuesday. I didn't hear till Wednesday. It was around 6 o'clock, and I was in Super Target grocery shopping. And that's when I found out I had cancer.
For Paige, time dragged on, waiting for the call. Then, during an ordinary moment, grocery shopping, checking out, children with her, everything changed.
I just couldn't believe it. At this point, I kind of had read enough about the way my tumor presented that it was probably not going to be good. But there's a difference between you've never had cancer and you're a healthy person. I don't take any medications. I exercise. I don't take anything. I don't have high blood pressure. I don't have anything. I'm just here. I was a 52-year-old healthy woman that worked out every day, drank water, ate healthy, But hearing it, you're just like, seriously? It was like, oh my gosh, it's the most awful thing to hear. It's just really, it was hard. And I had two of my kids with me, and I was just like, okay, I'm checking out at Super Target. And she's scanning my things, and I'm just like, what?
For Paige, that call marked the beginning of a completely new world, one filled with unfamiliar terminology. Words like grade, differentiation, markers, and Ki-67. Most of those answers come directly from pathology. And for many patients, those words arrive all at once, in the middle of diagnosis, when everything already feels overwhelming.
When the pathology came back, there's a lot of different markers that they look for in addressing high grade, low grade, what the cells look like under the microscope, poorly differentiated or well differentiated. Because while there is a high grade and a lower grade, there's some in between stuff too. So the pathology is pretty important so that they know exactly what they're dealing with. And that helps guide, maybe the order of medications or perhaps which medications they use and in what order they may use them.
For Paige, understanding pathology is critical, and the accuracy of the pathology report makes all the difference.
You will get the wrong treatment if you're diagnosed, for example, you're diagnosed with high grade, and that's not what you have. You have a mid-grade, well-differentiated neuroendocrine tumor. That could still be a high-grade tumor, but a well-differentiated tumor isn't treated the same way or with the same medications necessarily than a high-grade, poorly differentiated. So when they start you on treatment, it's just not going to work.
But what exactly is pathology? Where that tiny piece of tissue reveals so much information about a person's disease. To understand, Dr. Neil Rennick demystifies the basics of just what pathology is.
Pathology is really the study of human tissues and human disease tissues in particular. And the idea is really to get a diagnosis and then to see if there's anything in that tissue that could tell you anything more about the disease, like how badly it's going to affect the patient's survival, what medications might work on it. So really, we're just investigating disease.
To understand how pathologists approach this work, it helps to hear directly from someone who studies these tumors every day. Dr. Jerome Cross focuses on understanding the biology of neuroendocrine tumors.
And I'm a professor of pathology in Beaujon Hospital, which is in the north of Paris. And it's a center dedicated to digestive disease in which the neuroendocrine tumors, both from the pancreas and from the small bowel and from other digestive organs, is really a major focus of the hospital in terms of care and of my research unit. Who is interested in sort of understanding the heterogeneity of neuroendocrine tumors, why some evolve really quickly, some evolve less quickly, why some respond to some treatment and some don't, and to try to better tailor the approach to the patient in terms of intensity of treatment, intensity of surveillance. So trying to sort of improve the care.
And in neuroendocrine cancer, that investigation has to go deeper. So pathology is not only trying to answer, is this cancer? It is trying to answer, what kind, how aggressive, and what exactly are we treating? Dr. Aman Chauhan dives into this process.
So when they look at it in the microscope, they're trying to tease out first the big picture thing. Is it cancer or not? Once they figure that out, what type of cancer? Is it a leukemia, lymphoma type of cancer, or is it a solid tumor? So they keep going deeper and deeper. Eventually, in our world, we are dealing with neuroendocrine cancers. And since it's not one single entity, I would like to know what type of neuroendocrine cancers. So the pathology colleagues, they look into these factors like Ki-67, the morphology, and different stains beyond that. So to unpack that, the big things that we are looking at is, what are we dealing with? Is it a neuroendocrine tumor or neuroendocrine carcinoma? And that distinction is made based on morphology.
In simple terms, morphology refers to the study of the size, shape, and structure of cancer cells and tissues. It describes what cancer cells look like under a microscope compared to normal cells.
If the cells look in a particular way, they have a particular appearance, form, the pathologists are able to tell this is a poorly differentiated neuroendocrine carcinoma. And there could be even further subtype. It's a small cell or large cell type, as compared to well-differentiated neuroendocrine tumor, also sometimes used to be called carcinoid tumor. So they are able to differentiate it based on morphology. That means looks or appearance.
A biopsy may look simple from the outside, but inside the lab, it becomes a series of careful steps, preserving tissue, slicing it, staining it, examining it, all so that pathologists can begin to read what the tumor is revealing. Dr. Nancy Joseph explains further.
I'm a surgical pathologist, and neuroendocrine pathology happens to be one of my special areas and research interest areas. But for all surgical pathologists, what that means is we are trained to look at patient biopsies and resections under the microscope. So if you have any biopsy or surgery, your specimen is going to go to pathology. We're going to cut slices so that we can stain them and view them under the microscope and look at the cells and the architecture and, the proliferation index using stains like Ki-67. We also look at proliferation just by looking at the number of mitoses you can see under the microscope. We make a diagnosis based on what your cancer looks like under the scope, what it looks like morphologically, and also how it stains with different antibody stains that we can use to type these tumors.
And today, pathologists have more tools than ever before to help them do that work.
Basically, when you get a biopsy of a large mass, that gets sent to pathology, and we fix the tissue, we embed it in kind of a wax, and then we cut very thin slices of that wax so we can look at it under the microscope. I mean, it's 2026. We have a lot of tools now to look at these things under the microscope. We can stain the slides with our regular stain is hematoxylin and eosin. That allows you to look at nuclear and cytoplasmic features and to assess whether or not the cells are dividing and how many are dividing. But then we have other stains like antibody stains that we call immunohistochemistry. So basically, you can buy an antibody for almost any different protein expressed in cells. If you stain these things for antibodies against synaptophysin or chromogranin, and they're positive, you'll see that under the scope that they're positive. That means they're expressing neuroendocrine markers. Now, we also have antibodies against the specific proteins that are altered in these diseases, and the proteins are altered because the gene is mutated. So remember, every gene encodes a protein. So if you mutate a gene, you're going to lose that protein.
Those microscopic clues don't just confirm a diagnosis. They help to reveal how a tumor behaves and sometimes even how it may respond to treatment. And in neuroendocrine cancers, those distinctions matter.
But this is not enough. Once we have diagnosed somebody with well-differentiated neuroendocrine tumor, for example, then we have to take a deeper dive. What type? There are 3 subtypes of it. And these, we call them grade of neuroendocrine tumor, grade 1, grade 2, and grade 3. And how do we come about that? Is by looking at 2 markers, either or. And those 2 markers are Ki-67 or mitotic index. So these are the 2 ways the pathologist can classify neuroendocrine tumors, so grade 1, 2, or 3. And what it in a sense means, the higher the grade, more aggressive the tumor, more fast growing the tumor, more aggressive the biology. So this piece of information is very crucial for me to understand or prognosticate or predict how would the patient behave? How aggressive do I need to be? Do I need to start somebody on a hormone-based therapy versus start on some chemotherapy-based therapy? So all these pieces of information are very crucial in me understanding the disease, and it's provided to us by the pathologist.
Dr. Nancy Joseph further explains grades and proliferation.
In neuroendocrine cancers, biologically, grade is measuring how fast is this thing growing? Like, how fast is it dividing and proliferating? And we use two determinants for that. One is the Ki-67 proliferation index, which we use that's an antibody stain again, and then you can count up how many tumor cells are positive versus how many are negative, and that's that percent proliferation. The other way to do it is using just a pure count of the actual mitotic figures under the scope. You can actually see that cell in its division. You don't need a stain or anything. You can see the chromosomes all lined up and ready to divide, and we call those mitotic figures. And so if you have greater than 20 mitotic figures per 2 square millimeter, or a Ki of greater than 20%, that's grade 3, also called high grade for this cancer type. So it's a measurement of how fast is this tumor growing.
That complexity is one of the reasons pathology is especially important in neuroendocrine cancer, because these tumors can share features and still behave very differently.
Pathology for neuroendocrine cancers is complicated, and that's because there's multiple different types of neuroendocrine cancers, and they all share similar features, but they're actually very different. The behavior of these tumors and the treatments that they respond to are actually extremely different, even though under the microscope, they might share a lot of features. So it is very challenging to get an accurate diagnosis. And this is in particular for tumors that are high grade. So the lower grade neuroendocrine tumors are pretty easy to recognize and diagnose. However, once you get into the higher grades, like a grade 3 neuroendocrine tumor versus a neuroendocrine carcinoma, which is always high grade, that's when things get really tricky, even for pathologists and clinicians as well.
One of the reasons that pathology can be so challenging in neuroendocrine cancer is that the tumors themselves are not always uniform. Even within a single tumor, different groups of cells can behave differently, something pathologists call heterogeneity. Dr. Jerome Cross offers a helpful way to picture what that means.
So the heterogeneity can come, for instance, in a biopsy, you will have a very, very small pieces of the tumor. So it will be homogeneous because we are looking at 2 millimeters square. But when you deal with a surgical specimen, which, for instance, a tumor can be 6 centimeters, then there could be heterogeneity, meaning that the right part of the tumor might be, less aggressive than the left part of the tumors. And this is what's important to assess. Because if I only look at one tiny area, I might miss a more aggressive components. And if you think about it as a sort of a bag of M&Ms, you get all these colors. So the tumor cells is like this. And basically you come with one chemotherapy, it will kill all the blue cells. Okay, but you still have some red and yellow, which will grow. And then you come with PRT, which is radiotherapy. You will remove the yellow, but you still have the red, and so on. So I think the M&Ms is a pretty good sort of demonstration of what your tumor is that there is, at the beginning, it's all red, and then there's one blue that appears, and then the blue and red, they coexist, and a green one appears, and the bigger it gets, the more multicolor it gets, and then the trickier it is to treat.
The science behind these tumors can be incredibly complex. But sometimes the confusion patients experience isn't just about the biology. It's also about the language. Because in neuroendocrine cancer, words that may sound interchangeable to patients can actually mean very different things.
Unfortunately, we don't have great terminology in this area because in pathology in general, a tumor and a carcinoma in other areas are not different. Those words are more interchangeable in other cancer types. But for neuroendocrine cancers, tumors and carcinomas are extremely different. If you have a neuroendocrine cancer, you really need to pay attention to things in your pathology report, like what is that Ki-67 number and what is the grade.
And those distinctions matter enormously for treatment, making the role of the pathologist even more important. Dr. Chauhan explains how those distinctions matter if treating neuroendocrine tumors, or NETs, and neuroendocrine carcinomas, or NECs.
I think pathology colleagues are the unsung heroes of clinical medicine, definitely in oncology. They do the most crucial, most important work. And oftentimes, because they don't get the face time with the patient, their work doesn't get enough credit. For me, when I see or manage a new patient, the most crucial, pivotal piece of information is the pathology report. Because especially in neuroendocrine cancer, which is not a single disease, but rather a spectrum of diseases, it is very important for us to know what are we treating, NET or NEC or a mix of both. In my own experience, I see almost 15 to 20% cases that we change the pathology report or the diagnosis or fine tune it. And it's not uncommon out in community as well. So it's very, very, very important to get a very astute read on the pathology, get all the cases re-reviewed at a high volume net center so that we are 100% sure in terms of accuracy of diagnosis.
A biopsy can tell us a great deal, but is still only a sample into something that's living and changing. And tumors are not always uniform. One part of the tumor may behave one way, and another part may behave very differently. This means pathology is not only about naming a cancer, it's also about trying to understand the biology of something that may still be evolving.
In an ideal world, I would like to sample every single tumor because I know that there is a possibility of heterogeneity and tumors may differentiate and there might be differences between the primary. For example, we're dealing with a pancreatic neuroendocrine tumor with metastatic site in the liver. The Ki-67 index might be a little different in the metastatic lesion versus the primary. So there is always, in theory, that possibility. But there are logistical consideration, and we don't want to also subject patient for unnecessary procedure. So for routine care, a single biopsy to get the ball rolling, get our diagnosis going, our management started is usually adequate. Having said that, neuroendocrine tumor is such a unique disease, and it's not uncommon for us to see evolution of the cancer over a period of time under the stresses of the treatment. So we are now recognizing these grade migrations. So somebody who might have been diagnosed with well-differentiated grade 1 neuroendocrine tumor, and now the tumors are growing a little bit more rapidly as compared to historically how they were growing for that particular patient, that will raise red flags for me. And I would need to rebiopsy that patient to confirm has there been a grade migration or upgrading.
That complexity is one reason expert review matters so much. And it's also one reason patients may hear about re-review, second opinions, and the value of seeing a neuroendocrine cancer specialist.
Neuroendocrine cancers, every time there's an update, it does take a large amount of time for everyone who was practicing a certain way before to start using the updates. It's not an instantaneous thing. If you're being seen at a tertiary care center, which I highly recommend for all neuroendocrine cancers, since it is a challenging area. First of all, it's a rare cancer. That makes it challenging. Second of all, there's this confusion that we're much better at now clinically between those high-grade neuroendocrine tumors and the neuroendocrine carcinomas. So if you have a neuroendocrine cancer, I would say you definitely want to try and get seen at a tertiary care center, especially if it's high grade. You really do want to try and be seen by a neuroendocrine cancer specialist, because that's when, it really matters.
And for patients, understanding pathology is not just about learning terminology. It can shape how urgently they seek care, when they ask for a second opinion, how they advocate for themselves, and how quickly they move.
In my diagnosis at the beginning was March 9th. So March 9th will actually be 4 years since being diagnosed. He said neuroendocrine cancer. So he did not say carcinoma. And this was my primary doctor. I don't know that he knew. In fact, I'm pretty sure he wasn't quite sure what the difference was. So when I saw the oncologist, maybe 3 or 4 days later, I had to advocate for myself to see him that quickly. They were like, oh, he can see you in 3.5 weeks. I'm like, no. Someone's seeing me this week. It might not be you. So I was like, whoever it is, they're going to see me in the next few days. Or I was just going to go to the emergency room. I wasn't waiting. So I saw him the next day. And then that's when I started chemo a week later. So that's when I heard carcinoma. And as soon as I heard it, I went, I could tell by the sound of that, that's not good.
And for patients like Paige, they know the importance of advocating for yourself to get information, to get treatment, to get second opinions, and to see a neuroendocrine cancer specialist. That urgency comes through again and again in the neuroendocrine cancer community because time matters. And the more aggressive the cancer, the more the accuracy and speed matter together.
I think with any cancer diagnosis, it's important. But with an aggressive cancer, it's really important because time matters. Well, with neuroendocrine carcinoma, weeks, it matters. 2 weeks matters. 1 week matters.
For people living with neuroendocrine cancer that are listening, one of the most empowering things about pathology may be this. There are questions you can ask. You can ask what your diagnosis is. You can ask what your grade is. You can ask whether your pathology has been reviewed by a specialist. You can even ask to meet with your pathologist.
When you first meet with your oncologist, ask them about your diagnosis. Doctor, am I a neuroendocrine tumor or neuroendocrine carcinoma? Once you know that, then ask a follow-up question, what is the grade of my tumor? Is it a low grade, grade 1, 2, 3? If we are dealing with the NET. If we are dealing with neuroendocrine carcinoma, even then ask them, what subtype? Is it a small cell or is it a large cell? What is my Ki-67? When you ask these questions, you'll walk in very empowered. The doctor will know that you've done your due diligence. And that will sometimes also press on oncologists to get this information.
Dr. Nancy Joseph says patients should not hesitate to look closely at the pathology report itself.
Patients should absolutely be looking at their pathology report. They can be confusing, as I said, especially if it's not done by a neuroendocrine specialist. So you definitely need to look for that Ki-67 number. If it's not there, that's already not good. And in that case, I would ask, can we have this reviewed at a tertiary care center? Can we send my pathology out for a second opinion? Because, again, it's a tricky area, and every neuroendocrine tumor should have a Ki-67 in the pathology report.
Pathology is also not standing still. Beyond diagnosis today, it is helping to shape where the field may go, including the new ways to classify, detect, and understand these cancers earlier and more precisely.
Pathologists, they may study DNA or RNA or proteins, and the DNA are to look for genetic mutations. RNA is to look for gene activity, and protein is also like a functional, what these proteins are actually doing in the cell.
I'm also a molecular pathologist, and so like these sequencing assays, we can do them now on a blood sample, and I would actually is not too far off where, we can get to a place where the sequencing is affordable enough to just sequence everyone's blood. And if something stands out, then that person gets more workup.
I think what's going to happen in the field is that we're going to have lots of discoveries like this, and then we have to combine things, and that's probably the best way to do it. But I can see, having looked at the field, there's a number of proteins, and there's a number of other RNA markers, and there's some other tests that are coming. So I think combinations of those will probably enable at least a faster diagnosis, and I'm hoping earlier, and a lot earlier.
So all these pieces of information are very crucial in me understanding the disease, and it's provided to us by the pathologist.
Understanding pathology can help patients feel more informed, more prepared, and more empowered as they move forward. It can help turn a confusing report into meaningful information. It can help patients ask better questions and seek the right expertise, and better understand the reasons behind decisions for treatment. It can also remind patients and families that behind every pathology report is a team of people looking closely and intentionally at the evidence, trying to understand the biology of the disease as clearly as possible, so the next steps can be as informed as possible, and often create a clear roadmap for the decisions that come next. Thank you for listening to NETWise. I'm Jessica Thomas, Director of Patient Education at NetRF, and you're listening to NETWise, the podcast designed to inform, empower, and guide patients and caregivers through the world of neuroendocrine cancer. This episode was brought to you in part by the generous support of Lantheus, Boehringer Ingelheim, Exelixis, and ITM. Special thanks to everyone we interviewed for this episode. For more information, visit our website at netrf.org. You can find a whole library of episodes on different topics at netrf.org/podcast, where you'll also find infographics and videos that expand on this material. And if you would like to join NetRF in our mission to fund research for neuroendocrine cancer, or help support educational programs like this NetWise podcast, please go to netrf.org/donate. If you have a story to tell about your own neuroendocrine cancer journey, please email us and let us know. podcast@netrf.org. NetWise is a production of NetRF. We're committed to improving the lives of patients, families, and caregivers affected by neuroendocrine cancer. We fund research to discover cures and more effective treatments, and we provide trusted information and educational resources. This podcast is not intended as and shall not be relied upon as medical advice. The Neuroendocrine Tumor Research Foundation encourages all listeners to discuss any scientific information found here with their personal oncologist, physician, and/or appropriate qualified healthcare professional. Listening to this podcast does not constitute a patient-physician relationship. The Neuroendocrine Tumor Research Foundation does not represent that any information provided here should supplant the reasoned, informed advice of a patient's personal oncologist, physician, or appropriate qualified health professional.